and they will ask you which one is varicella and which one is hydrocele. So it's just simple to know the definition, and that is hydrocele versus varicella. So in hydrocele, like she said, it's just so if you look at the buzzword hydro, so we're comparing hydro versus varicella. So if you look at the word here, hydro, that means fluid. Okay, so it's just a fluid collection. Okay, and for another thing you need to remember about hydrocele is that it can resolve spontaneously, and you know, and you also need to remember that it will glow with what?
Transillumination.
Yes, trans illumination. So this one will glow with trans illumination. Okay, and another thing is if this patient is complaining of a testicular pain and scrotal swelling, like the patient that have a hydrocele, okay, and patient is complaining of scrotal pain, testicular pain, and scrotal swelling. So what you can order, so that is another point to order what? Doppler ultrasound. So Doppler ultrasound. So why are we ordering this ultrasound? We just want to rule out um, tumor or anything because it's supposed to glow with trans illumination, and this should not be painful. Okay, but if this patient start complaining about so Doppler ultrasound, if patient complains of what? If patient is complaining of pain, like testicular pain, or if patient you want to rule out tumor, any form of rupture and all that. So bear that in mind because if it doesn't trans illuminate, so that means there may be tumor, there may be hematoma, there may be other things. So you have to refer to urologist. Okay, so that is your hydrocele. So we said it's fluid collection, swollen. The scrotum is swollen because there's a fluid collection in the shaft that surround the, you can call it shaft, you can call it a tunica vaginalis. So that is your hydrocele. There's fluid collection. Then when you talk about varicelle. So varicelle is bag of worm. It's bag of worm because the varicose vein, the varicose vein in the scrotal sac, sometimes people have varicose vein on their lower extremities. Now, the scrotal sac looks like a varicose vein. So that is your varicelle. We call it bag of worm. And also remember that this can also cause infertility. That can be another question you'll be asked. It can cause infertility. Okay, so let's go move on. So just know the main word, varicose, hydrocele. So let's talk about cryptorchidism. Cryptorchidism. And cryptorchidism is the failure of the texts to do what? Failure of one or more texts to descend in the scrotum. So yes, when it fails to descend. And that is why I like to emphasize a lot on this topic, criticism, because if you are going to do primary care, it doesn't matter how busy you are in the clinic. If you have a newborn baby that comes in for maybe 2 weeks check, you have to make sure that the two texts are there. Those are the things you cannot forget. Try to remember to check for the two texts. It's the same thing like if adolescent comes in for physical, you cannot forget scoliosis, the Adam test. So those are very important to remember. So it does not descend up to the age of 4 months. So remember 4 months. So up to, because sometimes if it doesn't, they may give the child just a little time, but up to 4 months. So remember the word 4 months, up to 4 months. Okay. So, and also you need to remember that this causes a high risk of what? Higher risk of what?
Testicular cancer.
Cancer. Okay. So high risk of testicular cancer. So they always like to ask this question, high risk of testicular cancer. So please don't forget that, high risk of testicular cancer. Okay, that is your cryptorchidism, failure to descend. Okay, so let's talk about balanitis. What is going on with balanitis? Balanitis.
Looks like a yeast infection.
Balanitis. Okay. So that is the yeast infection, right?
Yes.
Candida infection, yeast infection. So they like to ask risk factors or high risk for factors. So what is the risk factors?
Diabetic.
Diabetic patient,
Um, if it's not cleaned properly, if they're not circumcised, uncircumcised.
uncircumcised, okay. Diabetic patient, uncircumcised patient, okay. So risk factor is your DUI. That is your risk factor. So what is your DUI? D is diabetes. U is uncircumcised patient. Then I is your what? Immunocompromised. Please don't forget this risk factor, DUI. DUI. Okay. And there are other things we know, or which is your, so under you can put 2U, which is also UTI. If the person have UTI, so you can include UTI there. So what is the treatment for balanitis?
Um, Diflucant.
Diflucan. Okay. For how long do they do the
It's a one-time
treatment?
dose.
One time dose. You We have over-the-counter, um, all those cotromazole, all those medication over the counter, and they can apply it 7 to 14 days.
Okay.
So DUI, and the treatment is ketoconazole or cotrimazole, because this is yeast infection. So 7 to 14 days. So let's go to our favorite, or my favorite, that is your Peyronie's disease. I hope all we are talking about, we came across it in the video. Peyronie's disease. So what is going on in this disease?
The crooked,
Yes,
but
that
the
is
crooked penile
penis.
direction.
Yes, crooked. And I made a simple way to remember it, which is your what? The acronym PPP. Are you guys following me, or I'm just here with one person?
We're following it. We're following you. I'm following you.
Okay,
We're here.
okay. No, it's not just one person that is here. So, but if she's the only one that wants to talk, I'm okay with that. I'm kind of person, when people talk, I retain it more. So anything somebody say to my ear, I retain it more. So that is your PPP. So what is P? We say that P, one of the P is plaque, but they call it fibrotic, fibrotic plaque. Okay, so because this is the it's an inflammation that is going on in the penis, and this inflammation, so you are saying inflammation of the penis resulting to resulting to those PPP. So the first P is plaque or fibrotic plaque. Okay, then another P we are looking for
Pain.
is perineal deformity. Okay, perineal deformity, or you can also call it crooked. Those are the words: crooked, perineal, and perineal erection. So that is another P: perineal deformity, crooked perineal erection, fibrotic plaque. Okay, and another P is the palpable nodules. Okay, palpable nodules. So however they describe this to you, they always use any of these words: palpable nodules. So PPP or PPP4. Fibrotic plaque. So the inflammation of this penis will result to fibrotic plaque, perineal deformity, crooked perineal erection. So even if you want to remove all this thing, you can just put plaque, perineal deformity, perineal erection, palpable nodules. So what type of surgery? We said the name of the surgery we use to correct it.
Nesbit's.
Nesbit's procedure. Okay. Next week's procedure. Next week's procedure. Okay. Okay. So let's talk about testicular torsion. Testicular torsion. Testicular torsion. What is going on in testicular torsion? Testicular torsion. So this is usually, the main thing to remember there is usually common with adolescents. So that is the first thing. One thing about men's health that will help you is always try to find out the age black and the age bracket. Also find out the risk factor. They always like to ask questions on risk factors, especially for men's health and the age. So, and they can describe it for you. You just need to remember. Okay, you just need to remember. So the first thing here is that it's common where adolescent. That is the first point. And another thing is that this patient is going to report that, and that is how they will describe it for you. Patient report waking up in the middle of the night or in the morning with abrupt onset of painful. So that is the thing that happened. So it's sudden and it's painful and swollen. Okay. And we said that this is a medical emergency. You have to send them to ER because they have 6 hours what window. So what are the two things that is missing? What are the two things that is missing in testicular torsion?
Crematoric reflex.
Crematoric reflex. So missing or absent crematoric reflex. Okay. What else? What else? Crematoric reflex and what? Absent crematoric reflex and what else?
I can't remember the other one.
Pharynx sign.
Pharynx sign.
Pharynx.
Yes.
Yeah.
Pharynx, yes.
So the first one is, excuse me, let me ask the question again. Did we listen to this video or not? Or we're yet to listen to the video?
I listened.
Didn't get a chance to listen yet.
I did listen to the video.
You did? Okay, one person didn't get chance to listen. So Benedict, you listened to the video?
Yes, ma'am.
all the men's health?
Yes, ma'am.
Did you come across the testicular torsion?
Yes, ma'am.
So you didn't remember that?
I did remember it, but I wasn't in the mood to talk.
Oh,
Okay, that is smooth to
Yes,
talk.
something is
Okay.
going on in my life. So if I
Okay,
always
it's
talk,
okay.
but
It's okay. It's okay. Okay. No problem. It's okay. So I just want to make sure everybody's following. It's different that you didn't get the chance to listen. So if you go this night, you listen. But remember, the idea is that we're supposed to listen to the videos. Then when we come, it's more of interaction. This is just a live section. It's not supposed to be a teaching section. It's not supposed to be a teaching section. It's a time we just try to regurgitate, and that is why I keep telling you to close your book, close your textbook, close whatever, so that you will be able to regurgitate what you have studied. That is the only way you'll be able to know if what you are studying is going in or is not going in. Okay. So she mentioned one is climateric reflex. So those two things, what they like to ask, crema, and that is how you can differentiate this from acute epidermitis. Because in acute epidermitis, the climateric reflex is present, but in testicular torsion, climateric reflex is absent. So you can say missing. Okay. But so if you combine, if you do testicular torsion and acute epididymitis, two of them, patient is going to complain of severe pain, both severe pain. But the difference is in testicular torsion, climateric reflex, and we say that is ferrin sign. Will be absent. That will be absent. So in epididymitis, it is present. So the testicular torsion, it is missing. So that climateric reflex is the one that when you tap, I'm trying to see, is the stimulation of the skin on the forehead, on the front and inner thigh. So when you tap on the thigh, okay, it's going to make like a little movement. And pharynx sign is when you lift it up a little, when you lift the scrotum up. Um, when you lift the scrotum up, the person gets a little relief. But in testicular torsion, they don't get a little relief or any relief. So this is actually good. So you just need to know climateric reflex and pharynx sign. So this is your climateric reflex. So if a patient comes in, you are not sure if this is testicular torsion or acute epididymitis, because like I said, both will complain of severe pain. So how do you know if this is testicular torsion, or how do you know? So what they do is this climateric reflex, they will tap at the thigh near the scrotum. Okay, the examiner strokes the skin in the upper medial thigh. Okay, and it will cause the climateric reflex muscle contraction. So That is it. Then the other one is if you do a little, like something, like if you lift it a little, the person will have like, the person will tell you, oh, I feel a little better. Like when you use like a towel or something to push it up a little, the person will say, oh, I have a little relief. But if the person do not have relief, then that is testicular torsion.
Just to add for the crematoric reflex, for those who have their husband, they can try to stroke the inner thigh. No, it works. Just test it. When you stroke the inner thigh, you'll see the scrotal sac just like it constrict, like it pulls together.
That was a good one. If the
Yeah.
husband will let them do it.
The husband or boyfriend, whichever
You are breaking.
works.
Hello? Hello? Oh, it's breaking.
You know, hear me? Yes,
No,
I
it's
don't know
breaking.
why.
Yeah, I said maybe the husband may not. Oh my God. But that would be a good one because, like I said, some of all these things, there was one thing that helped me when it comes to all those that helped me so much with musculoskeletal. I had to practice most of those signs, those maneuvers with my mom. Somebody that have like a lot of osteoarthritis or any, because most of the time when you are in the clinic, most of the time it's actually somebody that is normal. Except most of the time in the clinic, it's more normal people, except you are working in the hospital. So it will always be hard to see patients that have some of all these things we are talking about. You can be in the clinic for years, you didn't even see any patient with testicular torsion, you know. So, but some of those things, if you practice it with somebody it helps it to sink inside. Like when I practice the draw test, the posterior and anterior draws this thing, and McMurray, when I did that on my mom, how they said you will hear that click sound. You can, the first day I tried it, it looks like I've already broken her knee. But that is what it is because she have a knee problem. So if you do it on somebody that have a problem, you will actually appreciate some of all these things. But if you are just reading it, passing, it looks like it's not making sense, you know. Okay. But that is a good suggestion. Okay. So testicular torsion and okay, that is testicular torsion. If you also remember, you have to send this patient out immediately to ER. So if you know some of all these medical terms, it will help you during your documentation. Because if you don't know, if, for example, if you are documenting on a patient with epididymitis, of course, you are going to include positive crematoric reflex and positive pharyngitis. That shows you know what you are doing. Those signs. So that is why learning these signs is very important. It's very important. So let's go to the next one, which is prostate cancer and testicular cancer. Prostate cancer versus testicular cancer. So prostate cancer versus testicular cancer. So for testicular cancer, we say that things you need to remember, testicular cancer is mostly common with the younger people. So like 15 to 30 years. So if they tell you 20-year-old came in, so you already know it's a testicular cancer. There's no way it will be prostate cancer. Prostate cancer is mostly for older population. So remember I said men's health, you must pay attention to to age. A lot of people that see geriatrics, like when people take the exam and they keep asking, I don't know what is geriatric that's when people say, oh, my exam is filled with geriatric question, geriatric. So this is men's health is mostly geriatric question, I'm honest to you. And that is why you must know men's health in case your own exam have a lot of geriatric. And I tell you the truth, with what I have seen in the course of doing this, so many people, most of the people that fail in this exam, most of the exam is under geriatric and under musculoskeletal and skin most of the time. I'm not saying all the time, but most of the time. And the major reason why men's health is the easiest, for me personally, men's health is my easiest. Even if you wake me up anytime, ask me any question on men's health, I'm not going to miss it at this point by the grace of God because it's my best. I struggle so much on skin, struggle so much on musculoskeletal, and I got it at this point. But I'm saying for men's health, because one thing that helped me with men's health is that I saw the mistake people are making. People take exam on men's, and by the way, my own exam was more of geriatric population, which is men's health. And if I didn't spend time to find out all this mistake, there's no way I will know. Men's health asks you questions a lot about age, about age. You can run away from it. When they tell you, for example, like we talked about testicular torsion, we already said it's more common in adolescent. So testicular cancer is more common in younger population, which is cryptorchidism. We say that patients that have cryptorchidism is at risk of testicular cancer. So some of all this, the way I'm differentiating it for you, that is the way you can be able to remember and it sinks. So this testicular cancer is more in younger people, 13 to 15 to 30 years. And another thing is mostly common with white, okay? White male. Don't look and said, why are we spending our time talking about these little things? These are the little things that comes in exam. They say which of the following patients have the highest risk for testicular cancer, and they will put white, black, Hispanic, and all that. Sometimes in the exam, your questions can be like that. Which of this population will have highest risk of lupus? So you have to know all those, or patient that is at highest risk for osteoporosis. So all those things. So it's common in white male. And another thing is that you should remember anything about cancer. One thing to remember about cancer is that it's what? Feast. This is so simple, but even in the predictory exam we do at the end of the class, some people still miss this point. Feast nodules, that is cancer for you. Feast, feast. Or they can use the word hard, that is cancer for. Or they can use the word indurated. These are the words they use for cancer. Or they can use the word, what else? Sometimes they can use painless. Another thing they use for cancer is what else? Painless. Or they can use asymmetrical because this A made it to be cancer. For example, BPH, benign prostate hypertrophy or hyperplasia, is symmetrically enlarged, but they are going to put in the option like this, asymmetrical, and another one, symmetrical. So you just need to pay attention. Don't think that asymmetrical and symmetrical, they mean the same thing. They are not the same. So another word they use for cancer is irregular. Irregular. Okay. So, or they can also use the word um, heaviness. Heaviness. Or for testicular testosterone, this one is common. They can use one larger testicle. So one, this is for testicular cancer. So one larger. So you know why it's one larger? Because it is asymmetrical. Asymmetrical. So only one is affected. Asymmetrical. Okay. Or pain or in one testicle. So it depends on some cancer. Patient may complain pain, but most of the cancers is painless. So that is why I don't really talk about painless or pain. But fixed nodule, hard, indurated, painless. Um, some can be painless, some can be painful. It just depends on the cancer. Okay, some can be painless. So, what is the gold standard diagnosis for this? The gold standard diagnosis is your what? Gold standard diagnosis for testicular cancer.
Biopsy.
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 What type of biopsy?
Prostate biopsy.
Testicular biopsy.
Testicular prostate.
Okay. So these are the words they can use for cancer. Fixed nodules, hard, indurated. I can take off painless at this time because, like I said, some is painful, some is painless. It depends on the cancer. So fixed, hard, indurated, asymmetrical, irregular, solid mass, and heaviness. So that is usually for your cancer. But for testicular cancer, just remember it's more common in white, younger people. And the gold standard is testicular biopsy. So, but when you talk about testicular prostate cancer, so for prostate cancer, what are you going to see? It's mostly common for older people. So these little things can make a big difference. For example, even if when a patient is describing something for you and whatever, okay, let me give you an example. I was a patient, and sometimes it's when they complain this thing to you, if you're not careful, you forget what you already know before your mind will reset. Okay. So the patient was like, she always have this early morning stiffness, and that early morning stiffness, it especially in the morning, it looks like nothing is working. But after, she start moving around, she feels better. And I asked her, where is it? She just showed me one part of the body, like the one hand, or the leg, just one. And I said, that is osteoarthritis. And she said, why? I said, yes, osteoarthritis is unilateral, one part. But if you had it two places, like right hand and left hand, or right leg and left leg, that is bilateral, then that is your rheumatoid arthritis. So do you see how those two things made a big difference? If I didn't know one is unilateral and the other one is bilateral, and that is why you must know, all these things, at least those specific buzzword for each of those conditions. You don't have to know everything. We are not here to become experts. You are just here to know something that is specific to that. So, like I said, if I have a 50-year-old coming, I'm not thinking about testicular cancer. What I'm thinking about is prostate cancer. So, this is like greater than 50 and up. Okay. And another thing for this cancer, we say that patient is going to complain. It's more unique. And this is exam question. Patient is going to complain of what? Low
Low.
back pain. Low back pain. Okay? Low back pain. And also, which patient is common? Common is not that you can't see it in other patients, but when they tell you common, higher risk. So here, the difference is what? The other one was white. This one is African America. African America. And even if you don't remember African America, another risk, another trick to remember African America, obese, or obese patient, and family history. And this will lead us to PCA, PSA, sorry. So that is why I mentioned African America. Okay. So when you talk about PSA, men's health is so tricky. I hope you guys are getting all these tiny points. PSA. When you talk about PSA, yes, we have a guideline that says that the new guideline says that this should not be a routine check. Okay. And that is exam question. But if you have any patient, so in the exam, they tell you a 40-year-old. So remember we said prostate cancer starts with 50 years old. Where is it? 50, greater than 50. But the people that is higher risk is African America, obese, and family history. Okay, family history. Okay, it's just an acronym. It's not a good one, but we can use it. It's not a good one, I'm sorry, but we can use it. A fool. Permit me to use that word. It's not a good thing, but a fool. A is African America. F is family history. O is obese. O is older. And L is low back pain. This is, this. Again, I like to use acronyms. If it doesn't work for you, you can always find yours, okay? it helps me to study more and better. So this one is not a good one, but it's just to help me. So if it doesn't work for you, you can find one. But this five thing is very important for prostate cancer. You cannot avoid African American. You cannot avoid family history. Actually these two, African American and family history. So that brings me back to what I want to say. PSA. But if this patient is normally we start at 50 years. But if this, so in the exam, they tell you that you have a patient that is 40-year-old, African American. That is the buzzword. African American male. And the patient came in for physical. Physical, okay? What do you do? That is the option. It will tell you, tell the patient they don't need the screening at this time. Tell the patient to come back. Tell the patient. So the answer is usually start the test now. Because why? Because this patient has a higher risk. So people that are higher risk start at 40. So that is another way to remember this. Okay? People that are higher risk start at 40. Okay. I hope I am communicating here. Are we making sense?
Yes, could you just go over the full again? Family history, older age.
Family history, old age, obese,
Low back
Oh,
pain.
obese.
low back pain. It's all this thing here.
Thank you.
A fool. Don't say that I said a fool, okay?
Thank
I'm
you.
teaching you something. Some people
No, no,
we are
no.
not
It's okay. It's easy for me to remember.
some people no, some people actually we're not supposed to use bad words, but at this point, whatever you can use to remember. So use it to remember. So those 5 points there, you cannot avoid it. So that when you see question on African America, 40-year-old and all that, you already know. So that is your testicular prostate cancer. So this is your
Pastor,
testicular.
I have a question on this. So
Okay.
you said that that in PSA we start the test. It's not test regularly. We started
Yes.
at the age of 50.
The new guideline, you know.
The new guidelines say started, don't test regularly, start at the age of
Mm-hmm.
50. But
Mm-hmm.
if the patient has a history, like an example, African American male that came up for your yearly physical, so
Mm-hmm.
you have to do this PSA because he's one of the, he's in the category of the risk factors. Am I right?
Yes. Yes.
Okay, thank you.
So what is the question?
My question is, I want to be sure because
Oh,
I was
yes.
looking,
Yes.
I was looking forward to hear maybe like if they have a comorbidity existence in their life, you
No.
have to study.
The problem here is not the comorbidity. The thing here is 40 years for the fact that they have a history. That is the most important. It can be a family history, or they tell you in the exam the the father died of prostate cancer, or a brother died of course. They will be clear. They will tell you. So those are family history. Family history. So
And that take us back to the video because you were in the video you were explaining if the father, if they have a family history and
mhm.
maybe a sibling died, you there's something you say about you you double the age, you check.
No, no,
Oh,
that one you're saying is different. What
okay,
that is where I'm going now.
okay,
Yeah,
thank you.
yeah, yeah. That is where I'm going now. So the one you are trying to talk about, you see, if you don't understand that topics, it will still bring a little confusion where this one is and where the other one is, until you come to the point you are separating each one. So that one we are talking, she is talking about, is when somebody is on Prosca. Okay, Prosca, and that is when we talk about BPH. In fact, I don't know where to start from now, but under BPH, okay, it doesn't, so that it doesn't confuse us. So for prostate cancer, we have said prostate cancer, the age and all that, and also for prostate cancer, if the PSA, which is the thing, the PSA starts with what? 2.5. If it's less than 2.5, you check it every 2 years. Okay. This thing can be confusing. So correct me, less than 2.5. So check 2 yearly, 2 years. Okay. Then if it's greater than 2.5, okay, every year. So if it's 4, okay, greater than 4 or 4, greater than 4, refer the patient. If it's greater than if it's greater than 10, right? Biopsy.
Biopsy. I thought it
So
was greater than 2.5 need annual testing.
every year, that is it, annual.
Okay.
Every year and annual is the same, right?
Yes, never mind.
Yeah. Sometimes I'm not looking at what I'm typing, okay? So what she asked, this is the normal guideline, this thing. So that means if you check that patient PSA level and it's greater than 4, so the guideline is telling us to send this patient out, which is refer, send this patient out, okay? And they are going to do biopsy. Like you refer, it doesn't concern you anymore. If you refer the patient, you don't know what they are doing there. But for the fact that this patient is at risk, remember we're talking about somebody that is at risk. Refer the patient, and it's left for the specialty or whatever you refer them to continue, okay? But if a patient is on Prosca, it's telling us that if this patient is on Prosca and you do the PSA is 2.5. So what are you going to do? You are going to do what? Multiply by 2, right? So instead of saying that the patient is 2.5 and you are checking it every 2 years, the answer will be
5 and refer.
5, and that is refer. You see why men's health is tricky. So if they tell you in the exam now, a 50-year-old male PSA is 2.5, patient is on Prosca, and what do? And you chose the option that is every 2 years, because they're going to put annually, every 2 years, refer, and biopsy. I don't know if that is clear, Benedine.
Yes, that is clear on the Prosca patient, but where I was talking about was when it was saying that if the family member died of cancer, it was talking about when to do the tests, how often to do the test. It's not on relation with the Prosca in the video, but it was saying if the patient has a family member who died of cancer, and then you add the age of the family member, when to start testing the sibling of the person that has a prostate cancer. I tried to listen to that video. Maybe I'll go back to it again. But
Yeah, but that is what you answered. You start at 40 years. Or is there any other
yes.
thing? That is what you answered when you started. If the patient have a family member that have a history that is the same thing, even breast cancer. If there's a history in the family about breast cancer, the person has to start early, and it has really helped a lot of women. Instead of waiting for 50 years, they go for, at least I know one, she went for mammogram at 40, and she noticed that something is going on there, and right there she says she wants the two breasts to go, and that
Yes,
is it.
yes, you said that in the video too.
Yeah,
Thank
so those are the things. Anything if it's just family but another thing is, please don't make a mistake in this one. If you are is a little digression. Oh my God. Or is it the Prosca?
This meeting is
So
being
if you
recorded.
if you look at it very well, we give the hytrin, which is the one that we give pets, because the hytrin, it's is the first line of treatment, and that is let me put that again. Okay, how do we do it? Okay, so let's talk about BPH treatment. Okay, medication for BPH, which if you are going to have men's health, there's one probability you're going to see medication. So what is going on here? We call it alpha, because they may not say the name of the medication, but they will give you the classification. Alpha adrenergic antagonist. And I said another way you can remember this alpha adrenergic antagonist is alpha. We know what alpha is. Alpha is usually first. When you hear of alpha, alpha is usually first. So that is why this one is given, oh, sorry, is given first. And that is your flow mass. We call it flow mass, or which is your tamsulosin, right? Flow mass. So from the word flow, let the urine flow. So let the urine flow, okay? Flow mass, flow mass. And another thing you need to remember about this flow mass is that it usually causes what? Orthostatic hypertension. So that is why you tell the patient to take it when? At night. Flow mass is usually the first. Let the urine flow. Okay? Flow mass. Are you guys with me?
Yes.
Okay,
Yes.
thank you. So
Yes.
the urine will flow first. Okay? Then after that, another group is the one that we call 5 alpha reductase inhibitors. So from the word reductase, that means reduce. Okay? Reduce. So use it to remember reduce, and that is your Prosca. You know how Prosca, what does Prosca does? It shrinks. Okay? It reduces the size. It shrinks. So that is your Prosca. And you just need to know another word name. So just simple. If you remember all that I said from the word alpha, alpha is given first. Then that is flow. It helps the urine to flow. Then another group is 5-alpha reductase. So reducing. The Prosca helps to shrink. It helps to reduce. But another thing you always need to remember for the medication for BPH. Hmm? Any question? Hello? Okay. So another question is that um you can also give this patient herbal medication. And what is the herbal medication? So in the exam, they will tell you patient coming with symptom of, all the symptoms you mentioned here, and they will ask you what herbal medication can you give. So that is your salpamento. Salpamento, okay? So
Professor, just to clarify, so for BPH, the first line treatment is itrane.
yes,
Okay, so when do we now, where does Flomax now come in?
Flomas, they are all alpha andronergic. But
Okay,
hydrate is if they have BPH and
and
blood
Hypertension.
hypertension.
pressure, eh?
BPH and
Hypertension,
hypertension.
yes. So they are all in that group. Flomas, hydrate, that is the group. What is
Proscar.
in this group is no, Prosca is not there. Prosca is 5-alpha reductase.
Okay,
What is in alpha? The first one is Flomas, hydrate, and the one we call dosacin.
okay.
Okay.
Okay, thank you. So when does Proscar now come in?
Prosca is if you want to shrink it.
Okay,
That is a second option. Like if you give Flomas and it flows, urine is flow. It's not all of them that get 5-alpha reductase. It's like the same way we do GAD treatment. You start with PPI. It's not everybody that gets PPI and H2 blocker. It's the same thing when we talked about hypertension. Some
okay,
start with thiazide, and so it all depends. If the prostate is getting enlarged, and you want to shrink it, you give them Prosca to shrink it. But
right.
also remember contraindication for Prosca. A woman that is pregnant should not touch the semen. So if that woman is pregnant and the husband is on Prosca, they should avoid sex because you shouldn't come in contact with. The woman should not touch Prosca with bare hand. A pregnant woman.
Yes.
Imagine that kind of medication. They shouldn't
Mm,
touch it with a bare hand, and they shouldn't touch the semen. So they should. It's better to tell them to avoid sex. You know.
okay.
So that is for Prosca, and also, all these medications we mentioned, these two medications, very important for the exam. Medications that can worsen it is what? Anticholinergic, and the example. So you have to know the medications that can worsen it. So one is anticholinergic, another one is antihistamine, the congestant. So they can throw in any of these things here and there in your question. Anticholinergic, the congestant, TCA. So if a patient is on Hytrin, or patient is on Prosca, whatever, and patient is on which medication do you tell the patient to avoid? So the answer is over the counter antihistamine, the congestant, and all that. Why? Because we know that anticholinergic, the side effect is what? What is the side effect? It dries the person up,
Yes.
causes retention. So remember, somebody that is on anticholinergic, they cannot pee, they cannot
Right.
see, according to Hollier, they cannot see, they cannot, they cannot pee, they
Mm-hmm.
cannot, yeah, all those things. Okay.
Okay. Thank you.
Yeah, so thank you. But the most common one, the the most common one, they will tell you which of the following medication to avoid. I don't know how to call that word, but it's still under the same. It's either anticholinergic or antihistamine, or so, or depending on the medication that was given to you, you just need to pay attention. So example is, tell the patient to avoid, this is the medication, diphenhydramine, which is your what? Benadryl. So you see how it is. That is why men's health is so tricky. So they need to avoid um, anticholinergic, antihistamine, decongestant. Everybody knows some of all this medication here and there. Decongestants, caffeine, antipsychotics, and TCAs. And TCAs. Okay.
Thank you.
Okay. 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 Let me see if I can help with something. Oh, what is that? Avoid. What are they going to avoid? AA. Okay. Avoid. They can avoid. They should avoid AA. They should avoid. They should avoid CC. AACC. Okay. They should avoid. So this word is what? Act. Okay. They should avoid that, but you just that you added so many things in that act. So triple A, 2C. Okay. So what is that? A is the first A is your antihistamine. This thing I'm saying is very important for men's health. Anti
It is very important. That's why we are listening carefully.
antihistamine,
We listen to the video better. I think I'm understanding it more better now.
Sometimes I say these people that put this exam, they are just stressing people. Antihistamine, another A, anticholinergic. So it's left for you to know the medications. Anticholinergic. Another A is what? Atropine. They should avoid it. Or atropine. Okay. Another one is what? Our C, which is cold medication. They should avoid cold medication. Another C is caffeine. Okay. Then I didn't finish our A. A is 4. So antihistamine, anticholinergic, antipsychotic, which is very important because all those things have anticholinergic effect. So you should avoid this. Avoid C. Then what else they should avoid? They should avoid TCAs, which is tricyclic antidepressant. They should avoid it. or you can just put uh, okay. So D is your decongestant.
Are, are you typing?
Yes. You didn't hear me? Are we good?
Yes.
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 So Act D. I know why I'm emphasized on this thing. When we still talk about erectile dysfunction, in erectile dysfunction, the first line of medication too in erectile dysfunction is Viagra, erectile dysfunction. And in erectile, so this one is for BPH. No, yeah, BPH, right? Yeah. So the next one is erectile dysfunction. So in erectile dysfunction, in erectile dysfunction, um,
Pastor, please, can you show that last screen back? Can you show me the last screen?
so in erectile
I want to see
dysfunction,
the last thing you type.
that is the congestant. Are you good? So in erectile dysfunction, so erectile in erectile dysfunction, we already know that is because the man is not able to perform, and this is one of the most difficult parts for men. Okay, but what you need to remember is the lab. So what labs do we order when this man is not able to perform well? You want to look at the A1C, fasting blood sugar, and the TSH. Okay, so TSH, these are the options you are going to see: TSH, A1C, um, and the A1C of fasting blood sugar. So anything that has to do with glucose, fasting blood sugar. And the last one is your morning serum testosterone. Okay,
Is this
so
like
that is
select order applies, Professor?
eh?
Is this like select order applies?
No, no, it's not all that apply. They will tell you the labs to order include, sometimes it can be four labs in the option. They will just change everything. Like they will put A1C, fasting blood, and another one might be like um liver function test,
Oh,
something like that. They
oh,
always
okay.
put it. But if it's in ANCC can tell you select all that apply, three or
Mm-hmm.
two, depending on the option. Okay, so you need to know this lab. You see this lab and the one for patients that have delirium. Delirium is also 6 labs. Those 6 labs, you always see them in the option, but we haven't gone to that mental health. So what is important here is the treatment here is Viagra. So Viagra. So for Viagra, that is the treatment. What do you need to know? Do not use this medication with anybody that is on nitrate. So this is the one you avoid, nitrate. Okay. And another thing here is that do not use this medication Do not use it on any medication that prolong QT interval. And what is the medication? Even if you have not listened to me, you see this macrolide, some of you have heard me say it. It has a lot of interaction. Okay? So any medication that causes QT interval in prolonged one, avoid it. And also Viagra or Viagra, it can decrease blood flow to the optic nerve. So this is where you tell the person about they may have the risk of sudden vision loss, especially patients that have comorbidity like diabetes. So what are we saying here? Warning. That is how you see the warning in the exam, which is what? Sudden vision loss. So you encourage eye exam because why? It causes decreased blood flow to the optic nerve. So that is how you see, you are asking yourself what is the relationship between Viagra and optic nerve. This is the reason. And blindness. Okay. So the final one is your epididymitis and prostatitis. And that is the one you also need to remember. This one they like to ask it with age. With age. So for both epididymitis and prostatitis. This is bacterial prostatitis. Both this and epididymitis, the one we talked about with testicular torsion. If they are less than 35 years, remember, this point here is the most important thing. If this patient is less than 35 years, that is both prostatitis and epididymitis, they are complicated UTI. So if they are less than 35 years, you treat the patient as STD. And that is why we say that the organism here will be chlamydia or or what is that again? Gonorrhea. Okay.
Gonorrhea.
So if you look at it, the treatment
Gonorrhea.
is usually rocephin and doxy. So it's usually azithromycin, doxycycline, rocephin. But if you are talking about greater than 35 years, the organism here will be E. coli. E. coli. And the treatment will be complicated UTI, which is Cipro or Bactrim. I know they put liver, but most of the time we don't use liver for UTI. But sometimes I have seen in practice some people do that, but most of the time Cipro and Bactrim is what we give. Cipro and levofloxacin, they are all respiratory quinolones, but Cipro works better with UTI. And acute prostatitis, the buzzword is warm buggy. That is the buzzword. And another thing is CBC with left shift. That is it, which is presence of bands, immature white blood cells. So that is it. They have, because it's infection, they will have chills, they will have fever. So, but remember, prostatitis is a warm buggy, and if this patient is less than 35 years, that is, so if they tell you that this person came in, patient uh patient 30 years old came in with complaint of fever, this and that, radiating to the back, 35 years and 30 years, sorry, that is STD, treat it as STD. But if patient is 65 years, treat it as what? UTI. So that is one big gun you must know about men's health. Okay, we are just going to run down skin. There's no other way to teach skin. Skin is something you have to learn on your own. So what I do is when I talk about skin, I mention it. If you know what is the answer, you tell us. If you don't know what is the answer, write it down. When you go back, you study it. There's no other way you can do skin because that is skin for you. Skin is mostly definition. That is one thing about skin. Definition. They describe it for you. You just need to know. So a patient comes in and patient complain of patient coming down from hiking. Patient complain of red rash. Patient have a maculopapular rash, and patient complain of tick bite, and the name of the tick bite is rickettsia rickettsii.
Rocky Mountain spotted fever.
Rocky Mountain. And remember that this is a reportable disease. Okay. And we say that it's usually southern part. So you remember the acronym?
Yes.
Yes.
Mhm.
Then we have our Lyme disease. What is the tick bite for Lyme disease?
Borrelia
Fur.
burgdorferi.
Thank you. And we say that the difference is that this one is coming down from
North.
Northern
northern
path.
part, and that this one for Lyme disease, also remember if they are less than 7 years, you give them amoxicillin. But for Rocky Mountain, it doesn't matter how old they are, you give them doxycycline. But
Toxin.
yes, but in the exam, you may, if you see this in the exam, instead of doxy, what is, because we don't want to give a pregnant woman doxy, but some research says we can give. But in case you see this medication, chloramphenicol, give it instead of doxy. But if you don't see that, you only saw doxy, give doxy. Because there's a research that says that the amount of that the risk to the risk is greater than the benefit is greater than the risk, because it's just staining of the teeth, right? So that the 21 days or 14 days is not gonna cause more problem. So all this in a school of thoughts and guideline. But if you don't see doxy, you see chloramphenicol, go with that.
Is
You
it
have a
on Rocky Mountain
Rocky Mountain, yeah. Rocky Mountain said everybody gets doxy.
okay.
So, but and I said if in case you didn't see it, if you see chloramphenicol for a pregnant, remember for a pregnant woman, that is what I said. For Lyme disease, everybody, and also for Lyme disease, you confirm it. Okay, they do ELISA and they confirm it with Western blot. So it's the same thing as HIV. And Lyme disease is a target um, with bullseye lesion, red rash with bullseye lesion. Okay, skin is always good if you are looking at the pictures. Okay, then we have another one when you have a PPPP, which is a puritic plague, silvery scale.
Isn't
What is
it
that?
psoriasis? Yeah.
Hmm? Psoriasis, right?
Psoriasis.
So what if you have a new psoriatic plague over a skin trauma?
Or the
Color.
or the
Jesus.
Kalba phenomenon. Right.
Carbonal
Cup.
phenomenon.
Yeah.
So what
yeah.
if you have an area of pinpoint bleeding
Auspicious sign.
Auspice.
or speak sign? So that is why I like my acronym PPPPP. So this is all that we said here. So what is the psoriasis? P, 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 P. So the first P is psoriasis. The second P is our puretic. Okay, is puretic. And another P is a plague or plague. Some people will say silvery plague or silvery white plague. So P, okay, PPP, okay. Another one is another P, which is what? Pitting of the nail. So don't miss up this with um um iron deficiency. No, this is pitting of the nail. Okay, so pitting of the nail and puretic plague pitting of the nail. And one thing else you need to know is we have when we and the last P is pinpoint bleeding. The pinpoint bleeding. Okay, that is the 4P. Puretic, plague, pitting, and pinpoint this thing. And auspic sign is the pinpoint area of bleeding. Then the treatment is what they always like to ask, which is our tar preparation for mouth. Mhm. Are we good?
Yes.
Mm-hmm.
Okay, thank you. So always form something. Psoriasis, PPPP. Okay. When you have a velvet hyperpigmented patches, it's mostly in black, mostly in insulin resistant on the back of the neck or skin foam. Velvet hyperpigmented patches. What is that?
Acanthosis nigricans.
Yes, ma'am.
Acanthosis nigricans. Thank you. So they will ask you all of the patients are at risk, except so the ones that is at risk is your what? What did we say now? Insulin resistance, which
Resistance.
is diabetes. So diabetes resistant. What else? Colon cancer. They can use the word colon cancer or GI. So except is except is what is that again? Tinea vesicola. Tinea vesicola do not have anything to do with this. Then another one is obesity. So these are the ones that is at risk. Okay. When you have um you have a sublingual hematoma, you make a hole and you drain the blood. What is that?
Affination.
Strephination. Like I said, the one you don't know, write it down. All this thing is in the video. I will say that I am proud of myself in that skin video, whether you like it or not. I covered everything in that skin. So, the lizard said the lizard fell down from the height and nobody congratulated the lizard. And the lizard said, I will congratulate myself. So I will tell you, you see that skin? That skin is a good video. So anything you need to pass skin is in that video. There's no two ways about it. So you can look at it so many times and get used to it. So that is your trephination. Then we have impetigo. So we have two types of impetigo. So in summary, let me tell you guys so that we don't waste time. If you have any condition, that is how to answer your skin question. There's no two ways. It's as simple as that. So if you have any condition that is severe, if you have any condition that is life-threatening, I'm talking about skin condition, not everything. If you have any condition that you need a referral, that you need a transfer
BCD.
in case to ER, that you are worried about complications, something like this. What you are going and you are worried about massa, right? What you are going to do is what? BCD. BCD. What is BCD? Bactrim, clindamycin,
Docs.
doxycycline. Okay. These three medication, I have seen it in practice. I'm a wound care specialist. I love wounds so much, and I also do clinic part time if I want. I will tell you the difference between the two. I'm more kind of satisfied with wound because why I see that certification satisfaction is that one, I'm beginning to understand antibiotics and how it works because those are the areas that I struggled with before. Those were the areas that I struggled with before. So now I'm beginning to appreciate it now, seeing how that is why skin is making so much sense to me, you know, especially when initially I was so confused with skin. And I think that I was thinking in my mind that people that are dermatologists are fake. I said, how can all these rashes look the same? And they're saying it's not the same. There's difference. And I couldn't understand it. I couldn't explain the difference. I couldn't until God gave me this breakthrough that I'm beginning to see there is difference with all these things. So when I see the mistake providers are making, I'm not here to bring anybody down, but the more you know, the more it helps you to do better. I see this patient with this cellulitis in his leg, and already I'm worried about complication. I'm worried about massa. And I keep telling the patient, it's okay if you go to ER because I'm worried about something. I'm referring the patient. Maybe this patient may need to see a dermatologist. Maybe so what I'm saying is, I see this, I got to a point I had to call the PCP office. I said, I'm worried about this wound. For the first time, I was so concerned. I'll call this person. But the funny thing was PCP saw that kind of wound and they put the patient on carefless. So when I called the patient, I was like, carefless? And what I had to do immediately, and good thing the patient was finishing that carefless that week, I have to change the next week to doxycycline. So this is very important to know. Anytime you have any skin condition, that is why we said Rocky Mountain disease. You are worried about something, cellulitis. I'm worried about massa. I'm worried about this patient is going to lose his feet. I'm worried about something, especially when we are so aggressive. We don't want a patient to lose. You know what it means for somebody to lose their leg or lose any part of their body because of wound and all that. So when you're worried that, there was one patient I had to call. I said, you need to quit smoking if you want to save your limb. If not, you are going to lose it. I have to be so frank like that. I have done everything I have to do, every protocols I have done. And I told the patient, I'm not going to do your own protocol for you. I have done mine, you have to do yours. So why I'm putting up all this scenario is I was concerned. I was afraid there will be complication. What is the complication? They may end up losing their leg. What is the complication? They may end up getting wound, getting infected, end up getting septicemia, all these things. That is BCD, Bactrim, clindamycin, doxycycline. But for me personally, you cannot go wrong with Bactrim, you cannot go wrong with Doxy, you cannot go wrong with clindamycin. But the difference is that I don't like to do Bactrim personally. It's my personal preference. Why? Because you have to make sure patient is not allergic to what? To sulfur. Okay. And two, Bactrim always have sometimes, not always, they have effect on the kidney. If person have a kidney problem. So if patient have all this comorbidity, I like to stay away from Bactrim as much as possible. But Doxy works better. You can read it up with the heart. So for my older patients, I like to give them Doxy. Okay. So, but another question, which will bring me to what I'm saying. So this is for severe condition. If you have mild condition, if you have condition that is non-life threatening, if you have something that is like first aid, you are not worried about something. And those conditions can be like mastitis. There's no complication with mastitis. The condition might be like bullous impetigo. Another condition might be like, all these mild conditions. Something like mild skin condition, like if somebody have all this mild skin condition. Another one is erysipelas. Erysipelas. Okay, it's a mild skin. Erysipelas is a milder form of cellulitis, but you need to be careful to know when it's moving from erysipelas to cellulitis. Or if you have what we call hydantin suppurative. All this thing is mild. I'm not worried about something. I will just give the patient medication, follow up this type of patient, I will just tell them, follow up in 1 month, follow up in 2 months, whatever I want to do. But for this particular life-threatening one, even if you don't send them to the ER, they need to follow up. Sometimes it can be weekly, sometimes it can even be, you educate like this patient, I'm telling you, each time I educate him, I said, worsening symptom, go to ER. And you have to document it in your note. So I'm worried about something and I have to protect myself. But for this kid or lady here or man here, I don't care. I just tell them, okay, come back, follow up in this. So these people, what we need here is what? KCD, which is our Kefles clindamycin. So you see why clindamycin is here and clindamycin is here. So don't confuse it. But the major reason um, I want you to also pay attention. If a patient is allergic to Kefles, so and you want to treat something, you can give them clindamycin. And this D here is dicloxacillin, not doxycycline. This is dicloxacillin. And another simple thing to help you, for any skin condition, you don't know what is it, is a mild something, you can always do Keflex or amoxicillin, but you cannot do both. You cannot do both. You can always do one. And secondly, for amoxicillin, always pay attention to allergic reaction. If a patient is allergic to amoxicillin, they cannot get Keflex because which is Keflex is our cephalosporin. So they cannot get it. So that is when you can give clindamycin. Like I told you guys, I took my daughter to the dentist and I just heard the MA came in and told the doctor, oh, this person is allergic to Keflex. So what do we give? And immediately my mind is working so fast. What do we give? What do we give? You know. and the doctor said clindamycin. So that is smart. I remember my KCD, my BCD. Okay, so that is it. This slide here will save your life in the exam if you have skin condition, and even in practice, it's gonna help you a lot. If it's something that I'm worried, if it's, primary care is good. But I tell you, primary care is a lot. You just need to know everything. All these things we are doing, each one you have to know, one way or the other. That is primary care. Everything will come in there. Dermatology, condition, women health, all these things, all of them will come in for women and for primary care. So, but at the end of the day, everybody, you start finding out what is your passion and what you love doing. Some people end up in endocrine. We have nurse practitioners there. We have another one, which I'm sorry to say it, but I didn't like it before, but I'm beginning to develop interest. Is like this occupational health, people that deal more with musculoskeletal. So all those kind of things. If you are when you are doing this review with me, I know nobody knows where life is taking them tomorrow. Just kind of find your interest. Try to think about what you would like to do and which one gives you passion and all that. So from there, maybe in the future, you might start specializing. Some people is pediatrics, they end up there. Some people is women's health. Like I told you guys my story, for some things that I've always loved women's health, especially with journey of delivery and all that. But there are so many things at this point. That's why I can't go there for now at this point, because I'm not gonna be a good provider. It's either I'm biased or it's hard, especially when it comes to patient wants you to terminate the baby, or patients do not believe in keeping so things like that. So you still have to do your job, but remember, leak said you can transfer the person to another provider. So all those things, and for the fact they cannot get consent if they are underage and all that, because it has to do with STD, pregnancy, and all that. Emancipated minor, they don't have to take permission from their consent from parent. So always find what you like to do, and maybe in the future you might try to specialize there. Yeah, a lot of nurse practitioners now, they are going into uh, occupational health, and those people are so good. To talk about all those signs we are talking about in musculoskeletal, you must be good in that. Okay, some of you too will end up liking dermatologists. I know one of my students, her goal is to go there, and I believe she already finally got something to under dermatology. So some people, it depends on what you want. So let's continue. You have a patient that have this is central clearing and scaling. Is puritic rash, central clearing. I didn't say bull's eye lesion. Central clearing and scaling. What is that?
Isn't it, Tina?
Tinea corporis. Tinea corporis. Okay. So the difference is that there is no bull's eye lesion. Okay. And I talked about erysipelas. So remember, the erysipelas is the difference between erysipelas and cellulitis, which they like to ask, is the erysipelas is more of dermis, epidermis, like on the
Epidemic.
superficial, but cellulitis is more uh,
No,
deeper.
let me
So
say
if
that.
if you look at cellulitis, is deep dermis. Okay, if you look at erysipelas, is upper dermis. You can see the word upper dermis or superficial. And I have already said it, the treatment is diagnosis, which is our KCD. why the treatment here is BCD, because you're worried about osteomyelitis, I'm worried about something, I'm worried about DVT. Okay, so there is risk. And here they have a poor demarcation, while in cellulitis they have a well demarcated border. Okay, and like I said, for use of bathroom, you should always ask them, are they allergic to sulfur? Okay, so this point here is just penicillin allergy, use azithromycin, not Keflex. This is always exam question, not Keflex. That is not Keflex, because two of them, they have the same, it's the same thing like if somebody is allergic to amoxicillin and you are giving the person augmentin, that is wrong, because augmentin contains amoxicillin coagulic acid. So that acid there, and it has amoxicillin in it. So medication allergy is very important to note before you do any prescription. I'm talking to you guys already as people that already practicing, because I know that sooner than later, it won't be long. You are already in the clinic seeing patient. It won't be long. So we have our molluscum contagiosum. Oh, sorry.
I
For
have a
for
question.
another important thing is for erysipelas. Don't forget Group A. Don't forget this point. Group A strep. Group A strep. Okay. Group A strep. Okay. For for molluscum contagiosum, it's always from pus virus. Don't forget that. And we say that is white umbilicus or white plug. And we say that if you see it in the genital of the child, is an abuse, sexual abuse. That is your molluscum contagiosum. So remember, pus virus. We have talked about impetigo. We have two types of impetigo, which is bullous and non-bullous. So the one that is non-bullous, which is the one without blister, non-bullous, that is the one that the treatment is Bactroban. So you just have to look at the question. If they tell you it has it's a bullous impetigo, this is mostly for ANCC. Bullous impetigo, they are always specific in ANCC if it's bullous or non-bullous. But AAMP, they can just ask you what is the treatment for impetigo. Okay, so that is very important to note. And another big gun in the exam, both ANCC and AAMP, is this condition. We call it lynching planus. So this lynching planus, we say that is a flat top, red purple, or is a you can also remember it as PPP, because it's puretic, it's very itchy. And because it's very itchy, we say that it has always lynching planus is always as a result of it leads to what we call lynchinification, because the person will keep scratching the area, and it becomes very hard. When it becomes very hard, that is your lynchinification, because it's very itchy. So this is a simple description of lynching planus. You can see it. You can see it. So this is, you can see, it's purple color, it's puretic, is plague. It looks like psoriasis, but it's not psoriasis. This is very itchy. And another thing here, you see this white line, this white line. Some of them might not be clear, but you can see the white line that it crosses across. That is what we call the Wichingham striae, because they like to ask that word, Wichingham striae. Where do we have that? Wichingham, that is the white streaks. Okay, we call it Wichingham striae. Wichingham striae. Okay, we are rounding off. Okay, please. Also remember, for any form of bite, the skin, dog bite, we are giving them augmentin. Okay, and there's another big gun in the exam, which is Pityralis rosea. Pityralis rosea is a Christmas tree pattern. Okay, Christmas tree pattern. We call it what? PPP. Christmas tree. P. The first P is pattern. The second P is patch. Okay, patch, pattern, and Pityralis rosea. Okay. And for Pityralis rosea, the most important thing is to think about secondary syphilis for Pityralis rosea. So you always have to do the screening for syphilis, which is RPR, VDR, L, and the father apps. So, and the father apps. And you need to know, okay, let me say that soft, round, what-like is done, they said it's pasted on. It appears to be pasted on or stuck on. What is that?
That's the Z.
Seborrheic.
Yes, abort.
Seborrheic keratosis. Seborrheic keratosis. Okay. So this three is very important, which is soft, round. But the major thing in the exam is it appears to be pasted on or stuck on the skin. Then another one is basal cell carcinoma. The buzzword is pearly waxy lesion with telangiectasia. What is telangiectasia? Those tiny, tiny blood vessels. Then you have our melanoma, malignant melanoma, which is ABCD. So they can always ask you what is A, B, C. A is asymmetrical, which is the same thing I talked about cancer. B is irregular border. C is color. They will tell you that it has like blue-red color. That is the color. And D is diameter greater than 6 millimeter. And E is elevation or evolution. And the last one, but not the least, is our actinic keratosis. So I said that actinic keratosis is the baby, while the squamous cell carcinoma is the mama. And you have to take care of the baby so that it doesn't develop to the mama. So take care of actinic keratosis. Take care of it. So when you see something that is rough, scaly, that is the buzzword, it does not heal. A lot of patients have this because it's usually on sun exposed area. So because it always happens, you tell the patient that they are going to do what type of biopsy?
Punch.
Punch biopsy, thank you. So that is it. It will develop to the mama, which is squamous cell. The squamous cell carcinoma is the full cancer. But at this point, it is benign. Actinic keratosis is benign, you know. So you have to do gold standard diagnosis, and you can start treatment. At least I saw one of my this team perform this cryotherapy where you freeze. So they can do any of those things, cryotherapy or 5U cream. Okay, thank you all. I don't want to be bugging us with a long teaching.